The Blck Doctors Podcast highlights the stories of minority professionals with the goal of inspiring others. If you like what you hear, please subscribe and share with others, because the next generation can't be what they don't see. Tune in every Monday to hear our stories told by us.
Hello and welcome back to the Blck Doctors Podcast. I'm Stephen, your host. Today, I'm so excited to be speaking with Dr. Simone Maybin. She is a PM&R physician and she specializes in interventional spine. She currently practices in South Carolina. She's a graduate of the Air Force Academy. So thank you for your service, Dr. Maybin, and welcome to the show.
Thank you so much. I'm so excited to join you, and I'm ready to get into some of these topics you've come up with. Definitely put together a good list of topics to cover today.
Yeah, really looking forward to picking your brain because you've accomplished so many different things in different areas of the country and different very prestigious institutions. Also a fellow podcast host. You host the Healthy 365 podcast. So very excited to be talking with you.
No, thank you so much. I'm really flattered and I appreciate that. All those kind words.
Let's start kind of close to the beginning, but how did you decide to go to the Air Force Academy for college?
You know, my parents told me early on that I was going to have to figure out how to get to college on my own, and I thought they were kidding until I started bringing the list of colleges I was interested in, which are all, you know, kind of far-reaching. I've kind of been a driven person since I was young, and so I wanted to go all these really expensive schools, and my dad was like, "Oh, okay, so how are you going to go?" And I was like, "Oh, you're serious about this whole applying for things." So I did, you know, I created a little spreadsheet as a high school student. I created a little spreadsheet and applied for like over 30 to 40 scholarships. I was in JROTC at the time, so I applied for ROTC scholarships and got those. So that was kind of the direction I was going until a recruiter came to my school and, you know, informed me about the Air Force Academy preparatory school, which prepares you to matriculate into the Air Force Academy essentially directly after spending a year under like a sub-junior college curriculum there. And at first I was turned off by that idea, thinking like, what? No, like I'm great. I'm going to do good things. Like, right. You know, what is this junior college thing you speak of? But after I learned, you know, just how amazing of an opportunity it would be and how it sets you apart, I thought, well, the Air Force Academy really gives me that prestige I was looking for, that I learned that I, you know, through the process of how respected it was kind of in, you know, the United States. And then it would, you know, meet that goal of having it financially covered. And so I took that dive for the prep school, knowing that I would work my hardest and do well there and essentially guarantee me into a spot where, you know, getting into the Air Force Academy there's a less than 10% chance for those that apply. So essentially, gosh, I mean, I think actually the numbers are, it's a little bit harder than medical school.
Wow.
And so I said, you know what, I have to have faith, apply for that process, and kind of went for it. And when I got accepted, I was like, whoa, forget about these other scholarships. Like, I'm going to, you know, a great school, and, you know, I lifted that weight of, you know, the finance of the school from my parents. And so it's kind of a win-win from that perspective.
And what was your experience doing your time at the Air Force Academy? Did you fly planes during the summer and stuff, or what did you learn there?
Mm-hmm. Yeah, that's a good question. You know, the Air Force Academy offers you opportunities to focus on what you're interested in pretty early on. That first summer, you're focused on some basic requirements, so you don't have a lot of choice. So survival training, spending time, you know, in the Rocky Mountains, learning what it would be like if you were captive as a pilot. You know, there's a lot of tradition still rooted within the academy, even though it has progressed over the years. And so that's one of the traditional elements, is kind of going through a lot of summer training programs. And so I went through that. And then there are some other opportunities as you go through the summer to be the cadre or the trainers of the young people going through these development programs through the summer, and even the basic training. So eventually you are doing the basic training. And that is how you learn as a 19-year-old how to be a leader. You know, through your summer times, you're training the younger cadets how to go through these processes and working them through that curriculum. I spent a couple blocks of my time doing some summer courses as well to kind of lighten up my load. The Air Force Academy's load is, you know, quite demanding. Each semester is, 21 plus credits easily.
Oh, wow.
There's nothing like what I've heard from other colleges. And so anything I could do to kind of lower that. I was an athlete there. I was doing a lot of other things. And I found the academics quite challenging, to say the least. The background curriculum is engineering, aeronautical, astronautical, civil engineering, mechanical engineering. And it turned out I loved that, and I didn't know that. But as a person focused on going to medical school, what's the number one thing we care about? GPA, right? I'm like, whatever it takes to get a 4.0. So, here I was trying to balance all these military requirements, the sports, there's a physical fitness average, a PEA, just like there is a GPA. So they really push you to strive for balance in these three areas of performance: military, fitness, and academics. And it kind of pulls away from a personal goal, which is a great GPA to go to medical school. However, I think reflecting on that, where I'm at now, what do I strive for? Balance. I really want to be, a whole person within my family and friendship dynamic. I want to be fit and well-rounded within my personal life. And then I also want to do well within medicine. So, even though that's challenging, then I think it's rooted in kind of what a balanced life, what I perceive to be very balanced at this time. I had a lot of hard days there because of that push for the balance. And there's a lot of times I wanted to quit. And I never did. Obviously, you reach out to your family, and the people there are your brothers and sisters, and you rely on each other to push through it. And you remember your goals, and the idea of starting over when, the process is so long, it was overwhelming. And so all those things pushed me to kind of stick with it and just remember that it was all going to be worth it in the end. And you really just have to have faith in that, because it does really, really suck almost the entire 4 years.
Oh, that's a glowing review.
There's things you can't get anywhere else. You can't get, I could go on and on. The things you cannot get in any other school environment that you get at the Air Force Academy is just beyond. It undoubtedly has shaped my future, opened doors I wasn't expecting then. People don't even ask me about what medical school I went to sometimes. They're focused on the Air Force Academy. When I interview for programs, right now, when I interview for jobs, people talk about the Air Force Academy, and that was so long ago. And so not only did it develop me as a person and help me build this network of people that are closer than anyone else's, I'm sure they're random classmates in college at a traditional school, but it helped me to develop a foundation for how I'm going to survive when I hit the other bumps in the road that I definitely hit as I went throughout my life. That was just the beginning. And then everything else felt like possible, as I struggled through the other steps of med school and residency and fellowship. Everything seemed easier than the academy. And so there's a reason that I was supposed to go through that. And I'm thankful for that, because everything seems possible. And even when I fail, I'm like, oh, anyway, whatever, I made it through other things. I can do it. And so I'm very grateful to be from there, and I wouldn't change it. But I have to be honest about going through that experience. And most cadets would agree. You can't go through that experience and say, oh, it's all, sunshine and rainbows. It's just not, it's supposed to be a challenge.
Yeah, absolutely. I work with some Naval Academy grads, and there's something about the service academies where they breed leaders, and you definitely have a different perspective coming out of there, and it's evident.
Yeah. Well, thanks for asking about that. I haven't had to talk about the academy in a while.
Awesome. So Dr. Maybin, we're going to fast forward to medical school. You went to the Medical University of South Carolina, and along the way, I know you've been very active in the International Federation of Bodybuilding and Fitness. You are extremely vested in your physical fitness. Did that help push you into the specialty of PM&R coming out of medical school, or what led you to choose that specialty?
Yeah, the journey was definitely a journey. And I think a lot of people can connect with that when you're trying to pick what pathway to go into. Once you decide you're going to be a physician, some people might have set out, well, I'm kind of thinking about this. And then you are exposed to different people and different opportunities, and that helps to narrow you in. And that's essentially what happened for me. Ever since I was very young, I wanted to be a neurosurgeon. And so I went into medical school kind of just knowing that. And I'd done special programs like we all do when we're getting ready to go to medical school.
Right.
And I've been exposed to neurosurgeons, and a lot of them I was exposed to weren't the happiest of neurosurgeons. Now I know that it all just depends on who you meet along your way. But the ones I met along the way, I'm like, man, this does not seem like the field. People are not happy. And so I became more open-minded going through medical school, looking at other things that were just as interesting and hands-on, and found myself going towards the orthopedic route, given my background with health and fitness and being an athlete. And when I went and did a program at Hospital for Special Surgery in New York, I had the opportunity to meet a physiatrist on the rotation while I was there. So I was in the operating room and I was working with the female surgeons that work at the Women's Sports Medicine Center there. Awesome opportunity. And I still wanted to do that when I left, but I was exposed to that physiatrist to know that they even existed, and
Right.
They did some really cool procedures. So when I came back to medical school, I did a rotation there, and I started becoming more privy of that. I think actually med school, I started the interest group because we didn't have one in USC. So I started the interest group for that, so more students could be exposed to that and learn more about it. And the few physicians I could find to teach us and mentor us, we would do that. And so it was on my radar at that point. And then I started to learn how much it aligned with movement and function and mobility and fitness. I was like, man, this is essentially like fitness, but you're a doctor. How cool is that? And I became, drawn to that as a field. And, people that know a little about PM&R, actually not a lot of people know about PM&R, but a good way I break up PM&R is there's the inpatient side and there's the outpatient side. Inpatient deals with people that are greatly, permanently, and maybe not so permanently functionally declined after major catastrophic medical event, a stroke, a brain injury, multi-trauma, a spinal cord injury where they're newly paralyzed. These are the kind of functional changes that we're seeing on the inpatient side of things. And then the less traumatic and sad side of things, there's sports medicine and spine. And I knew early on I was more going to be more drawn to the outpatient side of things, and not because I'm not interested in those diagnoses on inpatient. I find those like exciting, and people think that's so devastating. Those people love to meet us and get better.
Right.
So inpatient rehab is a very gratifying field, contrary to what people think. But I don't like the inpatient lifestyle and the schedule. So really it was more that drew me to now I'm selecting between sports medicine and spine on the outpatient side of things. And then like any student, you do the rotations, you get exposed to things. And I was like, spine is it. Spine is it. I want to do hands-on. I want to do something ironically connected back to, the anatomy of the central nervous system, like I was always interested in back when I was 12 years old when I wanted to do neurosurgery, So it all kind of came back full circle, which, it's kind of funny when I think about it.
Yeah. Thanks for sharing, because I definitely didn't fully know the breadth. I'm learning more and more, mostly through like interviewing people, but how physiatry works and what PM&R docs do. But the breakdown of the inpatient and outpatient definitely helps clarify things. I know over the last couple of years, physiatry has become more and more popular as more students find out about it. So as you were applying to residency, you ended up going to Vanderbilt, again, a fantastic university, but you were kind of towards the beginning of their PM&R residency program. Is that correct?
Oh, I was actually the very first class that they started. So we were the very first class to start in the first graduating class of PM&R there.
Yeah. So what was that experience like, basically helping launch a residency program as you are yourself a resident?
Gosh, I feel like I have so many dramatic stories.
But dramatic or traumatic?
Dramatic.
Okay.
Maybe it's traumatic too, but no, I just feel like every chapter is, but it was hard. Like it was really hard a lot of times. I mean, when you're new, the curriculum hasn't been established and been proven that it works. So you're going through curriculum. Now, people always forget this, which is really important. Your attendings are not new, right? Like
Right.
these attendings have done physiatry forever. The chairman is one of the most respected physiatrists in the world, not just nation. The people he selected that follow him to that department are some of the most respected people in the United States and what they do in their respective fields. So we had the backing of outstanding faculty, and they knew what they were doing from a medical perspective. But there's the nuances of the curriculum that just have to be worked out as you go year by year. And I found myself being able to contribute to that because I'm interested in that. And I find myself to be a natural leader and want to be involved in developing something. And I actually said that in my interview there, is I'd be more interested in becoming part of a program where I could help build something because I want to use my military experience. Rather than going into something where everything we bring up as an opportunity for change, they used to say, oh, we've done it this way for 20 years. Vanderbilt wasn't going to tell us that. They're open to any suggestion you have at the beginning. And I think that is the good that came with the challenge of things were new for them. And I'm honored and proud that we have the opportunity to build that from the roots, but undoubtedly it's changed and improved year by year so much. And right now the program they have there, I wish I could be part of that program. That's what it's about, right? Like you want to be the foundation of something that becomes great. And I hope that those that come after me have a better training opportunity and those after them have a better training opportunity. And that's what they're doing at Vanderbilt now, is becoming, more fantastic and more, well fine-tuned and more unique opportunities. And so I'm glad that I was there, but it wasn't without its challenges as we kind of developed it along the way. I was like the first chief resident. And you can just imagine for you or other people that chief residents, what do you normally do? You go on whatever share drive there is,
right,
and you go on Excel sheet and you're updating them and you're filling them out. We were creating everything, right?
Geez.
Like everything had to be created. There was nothing to fill in. There was no, everything is on Wednesdays. No, we were deciding what days things were going to be on. So it was tough, but I don't think I would have done it any other way. It seems to be a trend for me.
Right. It definitely seems to be a trend. If there's no path, then you make one for yourself.
Yeah, that's true.
So as a physical medicine and rehabilitation resident, what types of rotations did you go on or go through during that residency program?
Okay, yeah, let me think this through. I love that part because there's so much breadth, and you really did get to refine that final year to do things that were more in line with what you were interested in. So some of the aspects of physiatry that people don't think of right away are palliative care. Palliative care, we actually did a couple months of, because some of the patients you will interact with are cancer patients. So they've gone through multiple treatments and they keep coming to rehab to strengthen, to go back through treatments. And then there becomes a point in which the physiatrist is part of answering the question, what functional ability remains based on the current condition. And so you need to be ideally comfortable with those interactions, even if not an expert. And so that was unique and great. I love that because building those communication skills that palliative care doctors have are, unmatchable if you have the opportunity to work with them. And then some of the other rotations, we work with neurology quite extensively. Seeing patients in the acute setting of stroke management is quite helpful because you get to see what critical decisions are made at the end of that stroke management as they get ready to transition in a more stable pattern to rehab. But then you also get to see how you need to manage those stroke patients if they do start to have recrudescence, which is reoccurrence of symptoms immediately after, and how to be comfortable with that and not freak out, and when to call the neurologist and just be able to manage that, confidently. Some other things people don't think of too commonly are working really in depth with the speech therapist and the physical therapist and occupational therapist. I mean, we got pretty intricate in the level of detail we worked with them because as physiatrists, one of the things most of us take pride in is we write very specific orders for our therapies. And you need to know what therapy exists out there. So for balance, ironically at Vanderbilt anyway, if there's a specific balance issue coming from the vestibular system, those actually go to the speech therapist. So there's all these nuances within therapy treatments that you learn by spending a lot of time with the therapist that you work through. We went to the outpatient cardiac rehab to see what those patients go through after major transplant surgery, after a cardiac transplant, a pulmonary transplant. I did a lot of ICU. It's people wouldn't think that that's super relevant. When we work in inpatient rehab, almost all those patients have died a couple times, and then they survive, and then they come to patient rehab. You have to know how to make people survive again until they get back to the ICU if they're transferring out because they have a complication due to their underlying condition. And so I did a lot of ICU rotations, and I actually loved it because there's a lot of procedures with ICU, which I enjoyed. We do a whole year of internal medicine because of that factor. So even though I was in a categorical program, which there's a mix, there's advanced and there's categorical, I spent that whole year doing internal medicine and covered the whole gamut at Vanderbilt, I was very humbled to be part of that group because it's so intelligent. And then as a pain physician, I started focusing at the end on going to work with the anesthesia group to see how they did things a little bit differently than the way PM&R does procedures. And then I spent a long time with sports medicine, and I worked with the concussion specialist. I mean, I could probably go on and on. I think that gives you a good scope of things.
Very, very broad and comprehensive.
Yeah, you definitely get a little bit of everything.
Yeah. I think it's super interesting that you had that initial interest in neurosurgery. You went into physical medicine and rehabilitation, and you kind of ended back in that neurosurgical realm when you applied to fellowship. And your podcast, Healthy 365, you have a recent episode that was titled I Failed and Landed at Hopkins, and that speaks to what you experienced when you were applying to fellowship. Fantastic episode. Encourage everybody to go check that out because I found it really motivating in terms of you think somebody has everything together and then, life hits them in the face and how do they recover and react? So you covered that extensively, but you went to Johns Hopkins for fellowship. And can you share more about what you learned during that year that you took the fellowship in interventional spine and musculoskeletal medicine?
So my fellowship was labeled as an interventional spine and musculoskeletal medicine fellowship, and some of them have that piece, and some of them don't. And so the focus of my fellowship, the first 6 months or so, was getting really good at basic diagnosis and conservative treatment of common conditions of pain, mostly coming from the spine, but we treat conditions from head to toe. With the fellowship director I worked with, that's really important because it all depends on who your teacher is. So fellowship director I worked with kind of knows kind of head to toe. If there's a joint or a nerve, then we can treat it. Not so much where you're getting into, the advanced dangerous procedures in the first 6 months, bread and butter, how to safely handle complications, how to handle, identifying patients that were indicated for conditions, and what were all the conservative options to offer them before we do the procedures. And that was the focus of it. And you did start getting into procedures very fast and heavy. Hopkins is a very high volume program. And so I did a lot of procedures in that first 6 months, probably equal to what people do in their first year. But the breadth wasn't wide. He really wanted my fellowship director wanted me to focus on, fine tuning the skills for the most common things in the peripheral joints and the lumbar spine that first month, the first 6 months. The other thing we added in that first 6 months that I really, really wanted was the EMG exposure with the neurologist there. A lot of people probably know that the neurologists and neurosurgery folks at Hopkins are, really impressive. And so any opportunity to talk with them, even for a day, is amazing. So spending a couple months with them, it really helps broaden you as a physician. And so we would spend time with the neurologist a couple times a week, seeing the patients that they would do EMG on. Now, as a resident, physiatry, we have to do over 200 EMGs to graduate residency. So we already have that experience doing them. And one thing you learn as you're going through that training is you and the neurologist have a little bit different way that they operate doing the EMGs and nerve conduction studies, and that they just have some different logistics, the way they set it up. And so it was great to go to a different institution at that point with all those skills under my belt And basically I could do the EMGs if I needed to, if I wanted to, and I was allowed to do that. And then I could also just sit there and learn and ask questions from them. And then I think one day a week I was with neurosurgery. So that's a really unique opportunity because you need to be able to hear what the surgeons say with certain conditions, what timelines they find to be critical for surgery, and just be able to have that language for patients because you are the one sending them to surgery a lot of times. And so developing that rapport with the physicians is critical so you can quickly get them in, but developing the terminology, the language, understanding what they find to be surgical indications and all these details they share with the patients was really helpful. And then that second 6 months with all that under the belt, kind of started putting some of those extra rotations away so that you could become, I was a senior fellow at that point as it changed, which means my responsibilities increased. I ran my own clinics. So I had a lot of independent clinics, not have my fellowship director there. And I think this is common for other fellows, but in this environment, it's pretty high speed and it's pretty busy. And so you need to be able to manage that. You're managing your fellowship director needing things. You're managing the other fellow if there's questions or concerns. And so now is the time to kind of start honing in on who you're going to be because, guess what? In 6 months you graduate and you're applying for jobs,
Right.
And so at this point too, you transition into doing more of the higher risk and more unique procedures like advanced devices, like spinal cord stimulator trials, kyphoplasties, the cervical procedures, and any other unique thing that maybe you just do once or twice a year. Maybe that's on your table at that point. And all along this time, spending 1 weekend a month doing inpatient coverage call as an attending. And so that's a good transition opportunity to have that attending role still as a fellow because you're done with all your inpatient qualifications. You can do inpatient rehab, leaving residency as a PM&R as a general PM&R resident and go do an inpatient rehab job. So I went to Hopkins and I would do that inpatient coverage as an attending 1 weekend every four weeks or something like that. And so that continued throughout the whole year. And did I love that? No, nobody wants to be on call. But in a way, I liked it because I got to practice having those confidence skills and, having oversight over the residents and letting them develop into who they're going to be and trying to be helpful and teach them what I know. And it was a good transition time. You weren't required to be the attending the entire time, but you had these opportunities to kind of develop your attending skills on the inpatient side of things.
Yeah, sounds like an incredible program. And you came out of there, you were looking for your first attending job, which you just finished your first year. Is that correct?
Yeah. I'm actually going into the last month here, which will finish my first year. So probably about 11 months now.
Yeah. So I am super curious and I wonder, how has this year been for you as you developed your practice style, as you literally built a practice? Can you tell us about that?
Oh, it's been so exciting. I really was a little bit overwhelmed by the idea of jumping in and helping the hospital develop that. So to provide a little background on the setting I work in, I'm in a hospital setting that is independent, a 501c, so not under the hospice of like an HCA or anything like that. So we are independent in that aspect, but we are a hospital system. And so in my hospital system, I am set with the orthopedic group and orthopedic surgeons. I'm the only one in the group and in my hospital that provides pain management, interventional spine management. And so I am the only physiatrist in the whole hospital. I do not do any inpatient coverage. It's all outpatient in that respect. And so I was asked to essentially bring the pain service line to the hospital system. And I thought it sounded exciting. I was looking for something different to do. There's a whole story about how hard it was to find a job during COVID and how I ended up here is a very long story. And so I ended up here. But when I looked at the opportunity of developing this in this unique setting that I never thought I'd be in, Myrtle Beach, I thought, this is going to push me out of my comfort zone. I don't think I'm a person that just goes to work and turns wrenches. I just don't think that's me. And I'm not saying that shouldn't be some people. I think there's something for everyone. I don't hate on that. Maybe I'll be that person in another chapter of my life, but I don't think that's me right now, that I wanted to go to work and just turn riches. And so I thought this was a great opportunity to come in with ideas, most of which I learned from my residency program, my fellowship program, all of which had their challenges with them. And I said, okay, well, I know a lot from all these. I think I can do it. I don't think, had my fellowship not been as well-rounded and challenging in its own right, would I have felt comfortable at all taking this job as a first out fellow.
Right.
But because I learned a lot about billing and scheduling, and I worked in 3 different surgery centers, I worked in 6 clinics, all of which work differently. I happened to be exposed into environments that I felt set me up to help them make the right decisions from an operational logistics standpoint to develop a pain service here. And so it has gone very well. Like, I'm really happy with the way it's gone, but I will say absolutely 100%, I picked the job because of the leadership, because the only way this was going to be successful is because of the leaders that I had. It's not about the location, the hospital, what color the office is, how new the building is, all this fancy stuff people think about, how many days you have off work. It's about the leaders that are there. And when I interviewed with them and I met them, I thought very highly of them. And I thought, the things they were saying were going to be delivered, and I was going to trust them. And that 100% has been the reason that I'm happy here, is because when I say there's a problem, number one, I'm not going to say there's a problem when there's not. I know how to deliver things and communicate things in a way that people take me seriously when I say there's a problem. But,
right.
I do think that they are like, oh, Simone isn't doing this for Simone's comfort. I've never asked for anything for my comfort or my schedule or for my paycheck. Everything I ask for is for the hospital, the patients, the staff. And when I say we need to, step back and take an opportunity to look at something, or we need to look at the way this is operating, they're like, okay, yeah, whatever, Dr. Maybin, let's do it. And will everything be fixed immediately? No, but they're always genuinely interested in helping refine it. And almost always I get what we need for the patients to have good care. And I think that's really the key here, is being able to, communicate in a clear way, objectively, about what you need for the patients, not putting yourself as the priority. The patients are always leading, the goals that I'm making. And then also being able to kind of have some foresight on what's coming and kind of help the hospital see what needs to be done next. And hey, I'm foreseeing this is going to be a problem when a surgery center opens in the month. We need to look at these aspects. Oh, okay, yeah. That's your job, and that's where you're hired. I don't think it's, it's not for everyone. But it's for me. It's for me, and it feels good.
Yeah, that's fantastic. And it goes with your vibe and your brand, very on brand for you, that you carve out your own pathway and it works, and your patients are so lucky to have you there to advocate for them. I know you do a lot of cool stuff over the last year. Can you describe for our listeners, we got some pre-med students, some medical students, what is a typical week like for you as a PM&R physician specialized in interventional spine?
Oh, I can't open the secret box. Everyone's going to know about the secret life of the good physiatrist. I do say it's the best secret in medicine. It really is. And I do think people are becoming more aware of that. We see that right now in residents. Almost the entire class every year now wants to match into a spine fellowship. And it really is a really great schedule. I work Monday through Thursday, essentially 8 to 5. And then Fridays are always a half day. That's just a hospital kind of standard in most of the clinics, is you work until noon on Fridays. I even came in asking, can I work in the afternoon? I'm not, I'm still all gung ho from fellowship,
Right.
And they're like, no, there's not going to be anybody there just being there. And that might change as we move clinics. But even today, I did procedures in the afternoon. All day Wednesday, I'll do procedures. And so those days can vary what time I finish based on how the procedures go. So you can have very early days where you're done before 5. I don't take call at all. And That does vary depending on your contract and what environment you go into, and what the requirements are. And so it's not like a default. This environment doesn't technically require that. And I had to explain that and let them understand there's literally no need for call. Either the patient, it needs to go to the emergency room because, God forbid, which has never happened, I've damaged their spinal cord, or the patient needs to see me in clinic. Like, there's no happy medium with what I do.
Right.
And so that's common. Most pain clinics, there is not a call per se. So it's not like it's abnormal, but what happens in some hospital systems is that physiatrist does some other things in the hospital, or maybe they're helping work outpatient call if that's a thing with that ortho group. And there's some other, nuances. However, I was really adamant about not taking the job on call, whether it was here or anywhere. I was not going to be on call. Like,
nice.
It's not necessary, and I will negotiate it out of the contract, or I'm just not going to work there. And so we made sure that was going to be true. And by the way, I'll caveat that with, I will always take a call if there's a complication after I do procedure on someone. And I've gladly taken calls to reassure patients after hours. So it's not like this solid rule. I have responsibility with the patients, but I feel like there needs to be a separation on a personal level, which is request. I have to have separation because I just give so much to these pain patients every day, and it's exhausting. And I think if there's longevity for me in doing what I do, I have to have my break on the weekend, and I have to have my break at night. And then you're going to get my all again 8 a.m. Tuesday morning. You're going to get my all again, after the weekend on Monday. I'm not going to be a disgruntled employee. I'm not going to be short with my patients. I'm going to listen. If I start pulling myself in areas I know I don't want to go as a physician, I don't think I would have the endurance to listen to my patients' full stories like they want and they deserve. And so for me, I knew early on I needed to kind of draw some boundaries and have my schedule to be very lined out, where it's just, this is what I'm going to do. I'm going to work these hours. I'm going to go home. I'm going to come back, and I'm going to be great for you. Monday morning, I'm always going to be great. 8 a.m. the next day, I'm going to be great. But I'm going home at 5 o'clock, and I work really hard to get my notes done at a reasonable time so I can leave at a reasonable time. Sometimes, obviously, there's things that prevent that, and I stay a little bit late, but I'm not going to be this person I don't do any work at home. I never don't do any work at home. I leave it all there. And I just have that boundary for myself. And so I think that schedule will change a little bit as time goes. It'll ebb and flow. And eventually I'll probably have 2 full days of procedures when we get to a surgery center. And there's some other logistical things that will change. That's common, just so people know. Maybe when I say a high volume physiatrist, I would 100%, I'm more of a high volume interventionalist. Some people in academic surgeons might do 8 procedures a day, which I'm not knocking. That's just what they're comfortable with, and that makes sense. And everybody needs to do what they're comfortable with, because that means the patients get the best care that they're supposed to get. But I do probably more in the 20s. And so in a high volume environment, you're going to have at least 2 full days of procedures a day, because that's the way you order. That's your clinical practice. I'm the only one here with all the surgeons. So my practice is busy and patients are demanding. So I personally feel I have to deliver. I can't just sit here and do a few cases a week. They wouldn't meet the need of the hospital system.
Yeah. And what procedures are you doing?
So I do procedures primarily on the axial spine, which means anything from the base of the skull down to the sacrum. And that can include cortisone injections. It can include radiofrequency ablation, RFA, or also known as burning the nerve. And then we do unique procedures where sometimes you find after surgery or a trauma, little nerves in that affected area, whether it be the joint, or sometimes after surgery, after hernia repair, there's a nerve that can be damaged in the abdominal area. Go figure. Well, I can find it, I can block it and treat it with cortisone, or I can burn the nerve. And so essentially, you can treat anything from the face down to the toes with medications to either prove that's the cause of pain by doing a diagnostic block, putting steroid around it to help fix it temporarily, or burn it to kill it forever. And there's such thing as a pulsed ablation, which we won't get into, where you can, with mixed nerves, you can decrease the pain threshold coming from the sensory part of the nerve. Wow. And so those are the most common types of procedures I do throughout the spine. and the rest of the body. If there's joints or nerves there, we can find it and fix it, hopefully.
Well, Dr. Maybin, we have been through so much together in the last half hour or so. Thank you so much for coming and sharing your story and opening Pandora's box on this incredible specialty of PM&R. Where can people go to learn more about what you do and kind of follow your progress and see what you're up to?
Yeah, well, thanks so much, first of all, for having me. It's always so fun to talk about the field of physiatry, which I think more people do need to know about, since there's a lot of great things within the world. And even if you don't go into physiatry, you need to know what physiatry can bring to your patients, right? And so an opportunity to share that information is always well received, and I'm so happy for that. Thank you so much. I have right now my Instagram, which is still building, but a great place to reach out to me. I'm there on a daily basis where I can receive questions, and I mean, hey, I'm always just happy for any kind of support. If I can support you in any way and you've listened to this, I'm happy to connect with any physicians out there that just want to have a fellow colleague in the field to be able to bounce ideas and questions off of. I think the more we support each other, the further we're going to get along in the long run.
Awesome. And definitely, if you get a chance, check out her podcast, the Healthy 365 Podcast. It's on all the major podcast platforms. Dr. Maybin, thank you so much for joining us.
Thank you so much. I hope that this was helpful for anyone, and I'm always available for anyone that has questions.
The Blck Doctors Podcast is a nonprofit, volunteer passion project with the goal of inspiring all who listen. Tune in next week for another episode of the Blck Doctors Podcast with Dr. Stephen Bradley, your friendly neighborhood anesthesiologist.